Hello. Welcome to these 3 brief snippets from our Master's and Diploma in Clinical Education courses. These are designed to give you just a brief sense of some of the things that we cover on the course. There are 3 things on the menu. The first, we will look at an everyday tool, that of questions, and have a think about how we can use them to better influence learning. Secondly, we'll look at another common tool, that of feedback, and look at particularly why constructive feedback is so difficult. Thirdly, we will look at the notion of development and learning as a process of identity formation. Again, a very important and very current theme in health professional education. So let's take a typical bedside scene. And this is where we want to focus on questioning. So students might be thinking, well, I wish I knew what was going on, because as teachers we often make the assumption that they do know what's going on, when actually they don't. It is very hard for them to appreciate the gestalt, the wholeness, the completeness of what is happening at the bedside, or in any case presentation. And indeed, students are often afraid of being asked questions, because questions for them are quite intimidating things. They expose their ignorance and often humiliate them. So how can we make questions somehow more supportive, a better and a more effective tool? Well, let's look at some examples of questions. So, for example, you might ask a student, well, what are the causes of, or what is the most appropriate antibiotic? And these are very common questions that we use. But the message to the student is very clear. It's a guess what's in my head type of question, and if you don't guess correctly, you're an idiot. What if you asked questions in a different way? So, why wouldn't you ask, what do you think is going on here? Or, how do you think that this man's urinary tract infection ought to be managed? Now, these sort of questions indicate that I'm interested in how you see the world, how you think. There's a very different message. Yes, of course, the student may have a wrong answer, but a wrong answer is an opportunity to explore misconceptions, to gently probe and see where that thought came from, to ask other students for their thoughts, etc. It's not an opportunity to ridicule. Okay, so that's just touching on something small to do with questions and question side effects that we cover in much more detail on the course. Let's think about a different issue, that of constructive feedback. So what is feedback for? Well, the purpose of feedback by definition is to have a conversation with someone about performance. And the express intention of that is to narrow the gap between actual and desired performance, and that would be lovely if that's how it worked. But how on earth can you have a conversation between one who is more powerful and one who is less powerful? The power gap has an enormous effect, and indeed can be quite a negative factor in the quality and indeed the construal of meaning in relation to feedback. One concept that has been very important for me has been the notion of thinking about feedback really as a feed-forward conversation. So, you give feedback to enhance feedback acceptance by the learner so they can learn better and improve performance. So how on earth can I get my message, therefore, so that everything I say here helps this person to do better in what they do? This is back to the idea of it being a conversation, therefore, rather than me telling someone what to do, or what was good or what was bad about a performance. So another issue really is feedback really construed by the learner as constructive? You see, what we always wish for in health professional education is that there is a very clear response in the learner to the feedback that we give, that we communicate it very clearly. We say, you ought to hold the catheter like this, etc., and there's some learning and there's change. The problem is, and the thing we always forget, is the learner gets in the middle. There is in fact a person here, and the person may or may not be ready to hear that sort of feedback, or they may or may not hear me as I have explained it. Any of you that have children, particularly teenage children, will know how difficult it is, even if you know what they should be doing, how difficult it is to give them feedback or advice that supports them in achieving something. In fact, they want to work it out for themselves. So it is the same with learners. In fact, when learners listen to us talking about their performance, they hear us in different ways, and I want to highlight a few of them now. first thing they always will think is, well, what's the credibility of you as a provider of feedback? And how does it fit with who I think I am, the learner, who I think I am? It's not conscious, this, it's unconscious, but it informs how they hear you and whether they will accept the advice, the feedback that you provide. So, for example, if the feedback doesn't fit with my self-concept, and particularly if it has a rather negative effect on my self-esteem, then I might be likely to initiate some defensive responses, such as, I'm going to reject this, or he doesn't really understand me, or this is demotivating, I need to stay motivated, I've got exams, therefore I'm going to park this, etc. So there are all sorts of reasons why you might want to defend yourself against such perhaps corrective or constructive feedback. Another issue is the credibility of the provider. And the most important feature of credibility is not actually your knowledge or expertise as a feedback provider, but it's how benevolent you are perceived by the learner. In other words, they're thinking, is this person actually trying to support me becoming better at something? Are they genuinely interested in my career? Are they interested in me performing better in my exams? Of course, they also, as a learner, would be looking at your perceived expertise and, of course, the perceived power gap. But in some respects, the greater the power gap, the harder it is for them not to, in fact, initiate defensive responses, because all learners are engaged in a business of impression management. They are trying to manage a benevolent and positive impression of themselves in your head. It's only normal. We all do it. The problem is that anything like negative feedback, for example, means that you are therefore construing them negatively, and they will do anything to try and rebalance that. So, some feedback tips for the 21st century, which really essentially are less of a daddy knows best approach, which is again back to my teenage analogy. So we have to use feedback to enable the learner to answer three essential questions. Where am I going? And that is really about what goals should I set for myself, but also what standards are you measuring me against? So we need to be clear about that. Secondly, how am I doing? So how am I progressing? Are you actually overall happy with how I'm doing? And generally, let's be honest, we are. Thirdly, well, having set those goals, understood those standards, knowing that I'm doing okay, but of course can always do better, where do I go next? And that's the feed forward thing. And obviously it'd be nice for you and the learner to agree what the next steps ought to be. A second important idea is the use of non-judgmental observations. In other words, play back what the learner did or what happened between them and the patient or other learners like a video. I noticed that you did this, and then I noticed that that happened, rather than saying, I thought this was good, and I thought that was bad. So keep your judgments out of it. It's easier for the learner to hear. You then also need to anticipate emotional responses and prepare for them. So what words are you going to use? Where are you going to meet? Are you going to do it in a public space? Are you going to do it in a private space? Will there be time for a private space? Because, of course, it's important for feedback to be timely. You need to also establish a culture of feedback where you work. And how do you do that? Well, one of the first and most important things is look for feedback on what you do yourself. Empower learners to give you feedback because they see things about the way you do things and the way that you act that actually they can comment on. If you create that environment, then they in turn will expect and welcome feedback from you. It's much more likely, therefore, if you're prepared to lose face. Now I'm going to move on to the notion of identity. So clinical training can be thought of as a process of identity formation. And why does identity matter? Because who we think we are informs how we act. I won't elaborate on this now, but this is a critical truth that you need to take on board. So who we are and who we are seen to be underlies how we think and behave. Identity and practice are actually mutually constructive, and what we mean by that is that what we do and how we speak and how we dress and all of that are expressions of identity, and how we speak and how we act, in fact, also inform how we feel about ourselves. Of course, it also informs how others see us. It's back to that notion of impression management that I spoke about earlier. Identity formation occurs in interaction with others. and that it is something that we do. We perform identity rather than own it. We don't own a single or multiple identity. In fact, we seem to be as flexible in our identities as the company that we keep. So, for example, when we tell stories about ourselves, we are actually positioning ourselves in other people's minds. Look at how you tell stories that involve yourself and that make you look foolish or don't make you look foolish, in which you moderate things to make yourself look more powerful, more effective or less, etc., depending on the company that you're in. Think about, for example, how you might explain yourself if you are speaking to a group of fellow experts as opposed to students. Look at how you position yourself so as to minimize their opportunities to ridicule you or question your thinking. These are all identity plays. These are all things that we do to present our identity and to represent ourselves as competent, capable, and on top of things. So, learners therefore do the same thing to us. They manage supervisors' impressions of them through using the jargon, talking the talk. Listen to medical students about using the word we to include themselves in the medical group or team or profession and so on. It's also about the attitudes that they perform, and they will try and perform attitudes that are congruent with yours. But if you're being unprofessional, then they too will mimic that. They, and we, always try to present cases in a manner that emphasize our competence as opposed to, in fact, what we're uncertain about. And yet, of course, this is vital, that if we're going to be truly self-regulating professionals, we need actually to prevent presenting cases and show the points of uncertainty, show where we went down a blind alley, and show how we recovered ourselves. But the point is, there's learning in this for everyone, and that I am open to ridicule, to questioning, because I actually value it, because it'll help me to treat patients better. And then also, if you watch learners, they will relate to patients and cross boundaries with other professional groups in a manner that they see you doing as well. So crossing boundaries or going across boundaries with other professional groups is actually a vital way of demonstrating professionalism, but it's also a way in which we demonstrate belonging to a group that is unprofessional. And of course, all of us at times have belonged to groups that were unprofessional, and we ourselves were tempted and perhaps did behave unprofessionally because we wanted to present an identity of belonging, of being part of something, and therefore getting good grades and good references. So clinical training then, from a social learning perspective, would view clinical professional teams as communities of practice, but also communities of identity formation. And that students in these communities learn to walk the walk and talk the talk. But what walk and what talk are they learning? And that is important to be aware of. Most learning for students in clinical settings is actually implicit, not explicit. How much bedside teaching do you really do compared to students traipsing around after you, following you, looking at you, mimicking you, and so on? So the hidden curriculum, therefore, is really the most essential part of clinical education. So what are the messages that you are communicating in your hidden curriculum? They could be good, you know. Hidden curriculums are not always bad. The team culture that you work within is always a conservative force. It tends to try and preserve our way of doing things, our way of seeing the world. And indeed, within medicine and nursing and physiotherapy, etc., there are these competing claims of science which privileges our particular group perspective. That is, that we are scientists in this business, and that there are, in fact, no other truths other than ours. In fact, there are so many perspectives. So, for example, how much do you privilege the patient's perspective in your consultations when students are present? Do you always say that there is our way, but what about the patient's way of looking at things? And then there is the privileging of being right. So we often let on that we know what's going on, when perhaps we don't. And then we often objectify patients. We call them interesting cases. But what does this do for students, for trainees, in terms of their thinking in turn about patients? And about them as real people with real problems who present things in ways that are quite unique compared to other people. And then, of course, we often within our conservative cultures, our communities of practice, have a very much a don't rock the boat attitude because of the fears that we have of retribution from further up in the hierarchy. And then, of course, we also often tell students not to display emotion because it's not professional. But how crazy is that? Because patients consult with us as people, not as robots. And then, of course, there is an intolerance sometimes within communities of practice, within our teams, within our conservative groupings, for individuality. Do we really tolerate? Do we really encourage difference? Because there is a right way of doing things. So in many respects, the messages, therefore, for being a supervisor here are really paying attention to the messages that we are construing in our teams, and particularly to learner safety within our teams. How safe is this learner to say and think what she really feels, what she really sees, rather than what she thinks I would like her to say or see? Start from where trainees are, rather than assume that you know what they know. So you need to observe them perform, as in case summaries, and you need to provide feedback, as we were alluding earlier, to on what the learners are actually doing. You need to give students and trainees roles in your clinical work environments, which of course gives them power, because if they have even small little tasks and roles and they're reporting back on these, it empowers them and makes it much more of a conversation when you're talking about feedback, rather than me like talking to my teenager though. Explain the big picture. This is critical before discussing nuances and details, because learners don't get the big picture, and thus in your questions and so on, you're helping them to see the big picture before we get down to the nuances and details, because we almost always in medicine make assumptions about what learners know, and in fact they don't know half what we think they know, and indeed they do know some surprising things that we didn't know they know. You need to expose your thinking so that learners can see as you see and learn to think like you think. And so that's it really, except to show you an image, which is that the best teachers are those who show you where to look but don't tell you what to see. And that is a message that I'm trying to take on board as a parent of my teenagers. I fail sometimes in that, but I'm hoping I'm getting better at it. All the best for now.